It's one of my own cases. An old female, 66-year-old, presented with diffuse bone pain, left-sided abdominal discomfort, and fatigue for the last several months. She also has an enlarged spleen, that is splenomegaly, and lab results show a WBC count of 1,67,000. And she's having anemia, the hemoglobin of 9.2 grams per deciliter, and platelet count is 7,30,000. So just by the look of it, this looks like a CML to me. Because of the moderate to massive splenomegaly, most patients experience a dull, dragging kind of discomfort in the left upper quadrant. And of course, you're going to palpate and find out, but this is the symptomatology. And because it's a chronic leukemia, you're going to have the B symptoms: fatigue, weight loss, bone pain, very common. And CML patients are known to have thrombocytosis, especially in the chronic phase, and they tend to have absolute basophilia, even though it's not given here. They've given the peripheral smear, though. What are you seeing in the peripheral smear? So some pathologists do call this as garden party appearance. But what is important to understand here is the left shift that are looking at here. So what do you mean by left shift? You're seeing a lot of granulocytes at all stages of maturation, which means indirectly I'm saying there are a lot of immature WBCs. So for example, in this peripheral smear, you can notice a probable promyelocyte, a probable myelocyte, a probable metamyelocyte over here, and a probable band form over here. So you can see increased number of granulocytes and its precursors, and they are at all stages of maturation. If you do not see maturation, and if there is maturation arrest or maturation block, you're going to think in terms of acute leukemia, where you'll see full of uniform cells called blasts. The only peripheral smear related differential diagnosis here is going to be the leukemioid reaction. We're going to see the left shift, which can happen in innumerable conditions, especially infections and sepsis, but the patient's clinical presentation is not compatible with leukemioid reaction. In the past, they tend to differentiate leukemioid reaction from CML using something called lab score, that is leukocyte alkaline phosphatase score, where lab score will be decreased in CML and it will be increased in leukemioid reaction. So of course, I can clearly say this chronic presentation, elevated WBC and platelets being elevated, patient being anemic, not much of a febrile illness recently, I will say this picture is very much compatible with CML. And knowing that this is a likely case of CML, what are you going to do? You're going to do a bone marrow aspirate and you're going to send it for cytogenetic. Cytogenetic means you can do karyotyping or FISH. Very commonly, we do something called FISH. And what is the expected chromosomal abnormality? It is the T922 translocation, which is also referred to as Philadelphia chromosome. Here you're going to have something called BCR-ABL fusion. And this abnormal fusion kinase is the one that's responsible for increased number of granulocyte precursors. And that's why it's a leukemia. So this is the expected chromosomal abnormality. According to WHO, without this T922 BCR-ABL fusion, you cannot diagnose CML. It should be there 100% of the cases. You cannot diagnose CML. But if you ask me whether T922 translocation is specific for CML or not, answer is no. It can be seen in a lot of adult ALL cases, almost 20%. And you can see in a lot of AML case as well, like around 2 to 3%, of course. So Philadelphia positivity is not very specific for CML, but without that, you cannot diagnose CML. So you need to consider the clinical picture, the blast count, plus at the same time, the Philadelphia chromosome to find out whether the patient is having CML or not. So this is a clear-cut case of CML. And this patient was treated with imatinib at a dose of 400 milligrams per day. And after treating with imatinib, which is one of a very, very important drugs in history as well, because if you study imatinib's history, you will love it. And this is one of the first tyrosine kinase inhibitors, first target therapies, which opened up a completely new domain in pharmacology called as targeted treatment and tyrosine kinase inhibitors. This is the first of its kind. Please have a look at it. Okay, so after starting imatinib, which is available in a brand name called Gleevec, at a dose of 400 milligram per day, patient developed near normal blood counts, which means she showed a very good response. However, she later developed shortness of breath, swelling around the eyes, and pedal edema, and the X-ray shown. So what is the X-ray showing? X-ray is showing a kind of increased vascular markings, and there is also kind of upper lobe diversion, suggesting that this is pulmonary congestion, pulmonary edema. And what is the most likely cause of the patient's volume overload and pulmonary edema? Simple, it is due to imatinib, because imatinib's important side effect is going to be volume overload and edema. And that's why it's important to know the important side effects of tyrosine kinase inhibitors that are used in CML. So imatinib, as I said, it's the first generation TKI that's used in CML. Then came the dasatinib and nilotinib, which are basically called as second generation tyrosine kinase inhibitors in CML. And then we have the ponatinib, which is the third generation TKI. Bosutinib, some classification systems call it as a second generation TKI, some classification systems call it as a third generation TKI. So it's okay. So bosutinib can be second or third generation, it really doesn't matter. So what are the important side effects? When it comes to imatinib, the most important side effect is going to be edema. Otherwise, it's a very, very safe drug. The most important side effect is edema. So which is a drug that's going to cause pleural effusions? It could be an exam question as well. One of the important drugs that cause pleural effusions in CML is going to be dasatinib. And what is the drug that typically causes gastrointestinal side effects like nausea, vomiting, diarrhea? It's going to be bosutinib. And what's a drug that's going to increase total bilirubin levels and lipase levels? So it can confuse you with pancreatitis. And most of these patients will be asymptomatic though, but one drug can increase lipase and bilirubin levels. That's going to be nilotinib again. And which drug is going to increase the QT, an increased risk of sudden death, significant QT prolongation? It's going to be nilotinib again. Which drug is going to produce hyperglycemia? In some patients, you can even expect new onset diabetes. It's going to be nilotinib again. And what drugs will cause peripheral artery occlusive disease? Peripheral artery occlusive disease. It's going to be again nilotinib and ponatinib. Both these drugs tend to produce peripheral artery occlusive disease. And which drug is going to produce thromboembolic manifestations? It's going to be again nilotinib and ponatinib, but ponatinib produces more arterial and venous thrombosis compared to nilotinib. Nilotinib also can produce thromboembolism, but when it comes to thromboembolism, I feel like ponatinib is going to produce more risk of thromboembolism compared to nilotinib, especially venous thromboembolism. DVT pulmonary embolism risk is more with ponatinib. So ponatinib's important side effect is going to be this venous thromboembolism and arterial thrombosis. What about pregnancy? All the drugs are contraindicated in pregnancy. You cannot use in pregnancy. Very, very important point. All right. And what is the importance of ponatinib? One extra edge point that you need to know. So it's the only drug, only TKI that's going to be effective in a lethal mutation called as T315I mutation. So this is the only drug that's effective. In case if you come across a T315I mutation, the only drug that's going to be effective is ponatinib, nothing more. And this patient's volume overload was treated, imatinib carefully reintroduced, and after successful imatinib treatment, the patient returns 46 months later with worsening fatigue, abdominal pain, and night sweats. At this point of time, the WBC count is 1,25,000, hemoglobin is 8.2 grams per deciliter, and platelet count is 80,000. So what are you seeing here? Patient is having elevated WBC count with other two lineages being suppressed. This is a typical finding that is seen in any acute leukemia, right? WBCs will be elevated, we'll see a lot of blasts, and other two lineages will be suppressed. Typical finding in a leukemia. This is how you diagnose leukemia in practice. And what the peripheral smear has to offer. Now you can see a lot of uniform looking cells. Previously, the smear showed a lot of non-uniform cells, right? At different stages of maturation. Now you're seeing a lot of uniform cells with a high NC ratio. And if you look at these cells, their cytoplasm is more granular in nature, confirming that this is a myeloid cell. And because I'm seeing uniform cells with high NC ratio, I'm going to call this as blasts. And because it's from myeloid lineage, these are myeloid blasts. We know that CML can go for blast crisis. And the most likely explanation for her current presentation right now is going to be transformation to acute myeloid leukemia. And anyway, we're going to continue tyrosine kinase inhibitors even in patients who get a myeloid transformation or myeloid leukemic transformation. But we need to start with AML-like chemotherapy. depending on the other issues like cytogenetics. And that's how this case ended up. And that's it. Thank you very much.